Hello. Thank you very much for the introduction. It is an absolute honor to be with you at this meeting of exceptional professionals. It has been an amazing experience up to this point in your country and in your city. After traveling in many places, I've found the Pakistani people to be incredibly welcoming, and the food is also spectacular. And I'd also like to thank the organizing team for this conference. They've done an amazing job ushering us around the city. So thank you very much. I will be talking about the early intervention for low back pain, but I'd first like to give recognition to my institute, the Ola Grimsby Institute. This is a picture of Ola Grimsby, one of my mentors. Let's see. And this is just a reminder to me that I'm a clinician above all. And if you're a clinician, you know the struggle of trying to help your patients. Research is important and beautiful, but in the end, it's the one-on-one interaction of trying to help people improve their lives. And so the clinical practice is really my passion. So why low back pain? Low back pain in the United States in a given year, 39% of adults experience low back pain, 80% over their lifetime. Most resolve, but up to 1 in 3 cases still have pain after a year. So putting that in Pakistani terms, 90 million people, Pakistani people, experience low back pain every year, and 30 million have ongoing pain after a year. And this pain affects their lives in a significant way. It decreases their enjoyment of life. They can't enjoy their family, they can't enjoy their movement, and it affects the economy as well. And the punchline of my talk is the sooner people with low back pain can get in to see a physical therapist, the less disability they will have. And this is borne out in study after study, and it comes down to accessibility in the end. And so for all of us as physical therapists and in this profession, we need to evaluate what are the barriers for getting people into therapy as soon as possible. Postponing physical therapy results in higher medical costs and a higher need for procedures. This was found in 2019 by Arnold. And Julie Fritz, who I highlighted here, is an amazing researcher from the University of Utah. And I always tell my students, if you see her name, read the article. She does great work, and she did a study looking at the cost effectiveness of primary care management of physical therapy. And in the United States, $90 billion, billion with a B, is spent annually on medical services, with an additional 20 million loss in work. So this is a very significant problem in our society. What she found in her research is delayed access to physical therapy. Okay? So that's not seeing a physical therapist for this problem early, meaning within 1 to 2 weeks, increased opioid use. And it increased the incidence of long-term opioid use. And in the United States, we're just coming out of a very severe opioid epidemic, and the ramifications in society and socially are lasting now, including homelessness, crime. It's touched us on many levels. Delayed access also leads to increased imaging, which is not associated with improved care, and also increased surgeries and procedures. So the earlier people with low back pain can get in to see a physical therapist, the more they can avoid these useless things. And this is just another study, evidence showing that with a delay in care for physical therapy, there's more x-rays, imaging, injections, surgery, and emergency department visits. So physical therapy first is a clear visit. This is a study looking at, on the left, patients who went to physical therapy first. The dark column is emergency department visits. You can see that if people go to physical therapy first and they get educated and diagnosed, they can avoid going to the emergency department where if they're delayed. Okay? This is also evidence of decreased opioid use, which is sort of the middle blue column, and decreased imaging. So these studies become redundant. There was a study in Seattle, Washington, in the United States with Virginia Mason, which is a big hospital there, and they put this into practice. They incentivized patients to go to physical therapy first, not to their primary care provider, not to an orthopedist, physical therapy first. And as expected, it saved patients from longer experience of pain, it saved the costs of surgery and interventions, and it costs imaging. The only problem is, in the United States, where medicine is an entrepreneurial experience a lot of the time, it costs the hospital money. So you would think with these amazing results and impact on society that it would be implemented across the board. But it was bound to fail because economically it didn't serve the big hospitals. It's a sad evidence of what medicine looks like when business is kind of the priority. So each of you, for being here, are leaders in your profession. You've made the effort to get here, and now you need to identify what the barriers are in your community for getting people to physical therapy sooner. Is it public awareness? In the United States, there's a massive campaign from the American Physical Therapy Association to reach out to the public, to educate them that we're there for them and they can see us. Is it a legislative scope of practice? Is there some barrier in your laws? Is it a financial thing? Is it the availability? We have issues with availability in the United States right now. There's a workforce shortage for physical therapists. We're producing a lot of new graduates, but many more are leaving the profession. It started with COVID and it's continuing. And then there's the evidence for what we offer. We need to get the message out. So it's incumbent on you to identify barriers. We have amazing services to offer to improve people's lives directly. Without drugs, without surgery, we need to find a way to be available. It's important that we also keep track of what the best practice is. Because if we remove barriers and we get patients to come to us, we need to be ready to take care of them. We need to be excellent. We need to be better. Whatever your level of practice is today, it can be better. That's true for everybody in the room. It's true for me. So this article from 2020, British Journal of Sports Medicine, identified 11 factors for best practice of physical therapy. It's simple things. First is, care should be patient-centered. That's our expertise. We are patient-centered practitioners. We meet people eye to eye and face to face. We listen to them. We learn what really matters to them. This is our wheelhouse. Okay? Screen for serious pathology. We have to have those skills. Assess the psychological factors. Without that, we can't have success. Without having a therapeutic alliance, assessing what psychological issues they have, we're bound to fail. So it's part of success. Only use radiological imaging if indicated. I was involved in a fantastic pre-conference session yesterday on the cervical spine. Great questions from very well-trained physical therapists, and the question came up several times: does this patient need x-rays? It's an important question, but knowing when this is appropriate and when not is part of being an excellent practitioner. And too much imaging has costs, not just financial, but on the psychology of the patient and their success. So assessing for serious flags helps you determine if imaging is necessary. Being able to perform a physical examination is crucial, and your patients will get their best evaluation from you. No other professional or practitioner will evaluate them in the depth, the thoroughness, and precision that you can do with the time you have. Take advantage of that. Get excellent at what you do. You have the opportunity to change these people's lives. We evaluate their progress using optimal measures or outcome measures. Provide patient education. That's a crux of what we do as physical therapists as well. Managing their physical activity, using manual therapy when appropriate, and using evidence-informed, non-surgical approaches. And finally, facilitating their continuation or resumption of work. All those things should be common to your practice. It just shows that how physical therapy is such a practical, excellent, spectacular profession. We need to just get the most out of it. And that's by being good. This is, somebody just gonna get fired. This is a study showing that the physical therapists that adhere to the evidence of those 11 factors have better outcomes. So what we have is, in the blue, physical therapists adhering or following those guidelines. They're having less cost for care, less opioid use, less imaging, less injections, less surgery. It just shows that the evidence is there. We need to utilize it. This is 4 levels of practitioners in the United States, from left to right, having more education. The first is just a therapist with musculoskeletal interest. The next is a fellowship. And at the end is a combination of a residency and fellowship. And you can see that they're using less passive treatments, education to stay active, and the more education they have, they're adhering to the guidelines. So it just shows that in practice, it'll make a difference. I referred to this study that was just released by the American Physical Therapy Association. And actually, this same study was conducted in Australia in 1990 by the Australian Physical Therapy Association, looking at the economic value of physical therapy in the United States. And I love the vision of the APTA. It's here: transforming society by optimizing movement to improve the human experience. That's what we do. That's who we are. And that's what the American Physical Therapy Association was working on, looking at 8 different diagnoses to see the value economically of starting with physical therapy. And the value is not just dollars, it's also time, energy, and sacrifice to get treatment. They found for these 8 different diagnoses that there was significant economic value. We knew this, but this gives us a platform to educate. Because in the United States, one of our barriers is public awareness. And this gives us tools to reach out to our community. These are the results for the different diagnoses listed in dollars. And you can find this information at apta.org, and this will be pushed out pretty aggressively by the APTA, and I'm sure you'll bump into it. It's got different graphics, specific cases about an individual patient and how physical therapy could save her time and money. Stress urinary incontinence was addressed as well. So there's different graphics. This is part of our effort to spread the word about what we can do. This next slide is very busy, and I don't expect to go through it. Oh, this is a little out of order. Let me grab this slide. Maybe. No, hold on. Excuse me 1 second. The point of the next slide is everything that I've talked about comes down to competence. And so if we can convince the public that we can help them, we have to be ready. We have to be excellent. We have to be competent. This is a flow chart that I use to teach students how to, in a detailed way, look at every tissue to come up with a diagnosis. We know there's other factors in terms of disability than just tissue diagnosis, but this detailed procedure becomes second nature, and patients come to us when we have this competence, and we can tell them with confidence, this is your problem. Because I looked at all of these aspects of you as a patient. And they feel that competence, and they listen to you. So your education will be much more effective once you have their trust. And in that way, we can be specific. We can lean on histology and how to apply treatment to make them better. For example, if they have a problem with osteoporosis, we know their diagnosis, we know how to treat that. We know how to apply stresses and talk about nutrition. It's specific to their diagnosis. If they have a disc injury, since we're talking about lumbar spine, we know that the disc is made up of annular fibers, which are made up of collagen, and we know how to load and stress collagen appropriately so that it can repair in a primary way. We can affect their biomechanics and take the load off so they can heal. These are just examples of the specificity that comes from the detailed evaluation. More pretty pictures of annular fibers. I think I'm running out of my battery here. Okay, this is a picture of articular cartilage. Okay, if we do our specific diagnosis and we realize the patient has some degenerative changes or irritation in the articular cartilage, how do we stimulate these cells optimally? What is the best stimulus to get change? Salam. The tissue diagnosis helps drive our treatment. More education in strengthening collagen. I think I have one more slide if I can get there. So we are the answer for the first choice of musculoskeletal problems. We're better for patients. We can improve society. We can improve their experience by making their movement more efficient and more pain-free. It increases the enjoyment in all aspects of their life. But we must always strive to be better. We must be excellent in what we do. Clinical excellence rises our entire profession. And all of you that are clinicians, you are at the tip of the spear for our profession. You are taking care of people in our community. You're the ones that need to step forward and get better. Finally, this has been an amazing experience at this conference and meeting many of you Pakistanis. So thank you very much. Sukiriya.
Thank you, Dr. K, for enlightening us with the best evidence-based approaches for the management of low back pain. Now I would like to introduce the next key speaker, that is Deborah Mudariki. Deborah is a dedicated physiotherapist with extensive experience in Zimbabwe healthcare. Since 2013, she has served as the clinical manager for the Zimbabwe Sustainable Clubfoot Program. Deborah's journey began with her studies in rehabilitation and physiotherapy at the University of Zimbabwe with 15 years of practice. Deborah's commitment to advancing her field is exemplified by her Master in Physiotherapy from the University of Witwatersrand, South Africa. Additionally, she serves as clinical instructor at University of Zimbabwe College of Health Sciences Rehabilitation Department. Today, Deborah will share her knowledge on the topic of physiotherapy-centered clubfoot treatment in the LMIC, lessons from the Zimbabwe National Clubfoot Treatment Program. Please join me in extending a warm welcome to Deborah Mudariki.
Good afternoon to you all. I'm very honored and humbled to be here today. Thank you to the university. Thank you to Miracle Feet for affording me this opportunity. I feel so special right now being here. I think I am the only person in the room who can safely say I'm coming from the southernmost part of the hemisphere. And there is no one else who has hair like me or who looks like me in the room. So thank you all for having me today. So, as already has been mentioned, I'm Deborah Mudariki and I'm a physiotherapist by profession. I work mostly in clubfoot work, and I work with Miracle Feet. Some of you may have seen our booth, some of you may have seen our t-shirts, and some of you may have seen the work that we're doing with partners here in Pakistan. Miracle Feet is mainly an organization that centers around addressing the problem of the clubfoot deformity, the problem of clubfoot, with the child being at the center of our interventions and at the center of our model. We focus mainly on working with the governments, with parents, community health workers, as well as hospitals and clinics, which is where you all come in as clinicians. We had a lovely pre-conference workshop yesterday where we spoke a bit more in detail about the clubfoot deformity. It is not a new concept, and I'm hopeful that most of you may have seen children with clubfoot already. The scientific name is congenital talipes equinovirus, and the global incidence of clubfoot is quite high. We expect every 1 in 800 births to have clubfoot. The deformity is mostly idiopathic, and only a small proportion is secondary, which is to say you'll find it along with other conditions like spina bifida and arthrogryposis. What we also know is over 2 million children under the age of 10 years live with this painful disability. And may I also add that it is an avoidable disability, and that is what I want to stress the most. And we all have a role to play in avoiding permanent disability from the condition. Okay. So when I was thinking after the invitation, what do I talk about? I thought Pakistan is budding, it's growing, it's revolutionizing in terms of clubfoot treatment and making this option of treatment available to children across the country. So what better way than to share the experience that we've had in Zimbabwe as well with running a national clubfoot program. Earlier on, when I started practicing, we used to manage clubfoot in my country using the kite method. And we faced a lot of challenges. That included the high cost of treatment, the repetitive visits that parents had to make to the hospital because we were not being effective with that intervention. We also had quite a high burden of surgery, a long waiting list because our patients would need additional surgery, and it just wasn't working. So in the end, we had very angry and discouraged parents, unhappy patients, and above all, frustrated rehabilitation practitioners, because we all know as clinicians, when we do our work, when we make our interventions, we want results, but we just were not getting those results. So the Ponseti method basically was introduced in 2011 in Zimbabwe, and it is known at the moment, it is the gold standard of clubfoot treatment, with mainly 2 phases, a corrective phase as well as a maintenance phase. And in the corrective phase, the clinicians mainly perform manipulation and casting, and the doctors or surgeons come in to perform tenotomies. The deformity is very stubborn, however, so we often have to prevent recurrence by using foot abduction braces to maintain the correction. Why was this technique a game changer? It's quite affordable. At less than $500 per child, it has been found that we can effectively treat the deformity or correct the deformity and ensure that the child goes from casting all the way to maintenance with braces just with that amount. The method is also effective. In 95% of the cases, all they will need is manipulation and casting, as well as bracing for maintenance. So Zimbabwe is the country I chose to focus on because we have quite a lot of similarities as well with you here in Pakistan. Our health system, the number of patients we're seeing may be smaller because of our population, but the challenges that we face and our needs are more or less the same. Okay. As rehabilitation practitioners, if you forget everything else that I say today, I want you to remember that in clubfoot care, there is great potential for task shifting. So what does that mean? It means that we as rehabilitation professionals have the capacity and the scientific knowledge that is required to be able to treat clubfoot effectively. Historically, in places where there are many orthopedic surgeons and doctors available, they really don't need to worry about physiotherapists stepping in to assist. But where we come from here in low and middle income countries, we need rehabilitation practitioners to bridge the gap. So that is our very own Zimbabwean first and only female orthopedic surgeon who also works with the clubfoot program, and that just goes to show you how few we are in terms of the clinical expertise, you know, in terms of surgery and orthopedics. So Zimbabwe is a small country, a small teapot-shaped country in south of the Sahara. We have an estimation of 538 new cases each year. That's new clubfoot cases. And we have a national clubfoot program that works in the country to support clubfoot treatments in government hospitals, mainly central and provincial hospitals. We also currently meeting 75% to 80%, 88% of the needs in terms of the children that are born by providing the treatment services in government hospitals through the partnership. I've already mentioned it was the Ponseti method was introduced in 2011 by a gentleman physiotherapist called Ryan Bathurst. He was here in Pakistan earlier on in the year and helped with clubfoot training. To date, Zimbabwe has seen over 5,000 children, which means over 5,000 children have been treated over the past 10 years. The main focus really that I want to share is the challenges that we experienced and the solutions that have been employed. Because what we've learned is we are different, but we are not so different. Our challenges will be the same, and I'm hoping that we can learn from each other and you will avoid the pitfall of making the same mistakes because your brother next door has already learned and warned you about these potential challenges. So the first challenge was we were operating alone. Ministry of Health was not a part of the National Clubfoot program. And that was a challenge because we didn't have the support to expand and to further train. So how have we solved it? To date, we've been able to establish a formalized memorandum of understanding with our government, Ministry of Health, and we have support for all the activities that we do and direction from Ministry of Health and associated structures. The second major challenge was the high clinic volumes when we started. We started small and we were really overwhelmed with only 2 clinics and very few physios having the capacity to assist the children. So training has continued to happen on an annual basis. There are more than 4 or 5 trainings for our clinicians, and we have continued to open more clinics from 2 initially to 15. The third challenge rather was the challenging cases. In all the clinical cases we see, we find there are always those outlying cases, the impossible, the ones that seem like we're really not making headway. And we did have that burden as well. But thankfully, through collaboration with the Global Clubfoot Initiative, with other researchers and other clinicians, we've been able to consistently and continuously have advanced potency training to make sure that we upskill, and we have regular mentorship and supervision as key components of the Clubfoot program. We cannot just train people and send them away. We need to make sure that they are mentored continuously and supported as clinicians. We're also having collaboration with surgeons and surgical hospitals who can assist when we need surgery or surgical intervention. And last but not least, we have early detection and referral programs that we work with the nurses, the midwives, the community health workers to spread the news, and other health workers as well, to spread the news and refer appropriately. The fourth challenge was doctors for tenotomies. You cannot completely treat a child without doctors or surgeons to perform tenotomies. Because of the lack of collaboration in the first few years, doctors were plainly unwilling to assist. But we've worked hard to build relationships and partnerships and networks and multidisciplinary teams, and engaged orthopedic surgeons as part of the core team to help with ensuring that all our children at all our clinics get tenotomies. The fifth challenge, as is known to all Ponseti practitioners, is the challenge of dropout during bracing. Because this is a long-term thing, the children need to come until their age of 5 years old, and it's a long process, so we're losing our children. But we were able to then introduce parent educators in the system, who are other parents talking to other parents about the method and encouraging them to comply and make sure that they keep coming to the clinics. So, in Pakistan, who are we working with to try and replicate some of these structures that we've spoken about? We're currently working with 2 partners in Pakistan who are supporting Ponseti treatment in 2 provinces. That's Khyber Pakhtunkhwa and Punjab. Apologies if I mispronounce that. I've been trying to practice. So we are partnered with PCP in KP province, and we're also partnered with ASD in Punjab, and those are the centers that we are working in, the 6 centers that our partners are working in to provide clubfoot treatment. We're also scoping, which means we're looking for other potential partners to work with, and we're considering working in other provinces like JK and Baluchistan. What is the burden of need here in Pakistan? What is the shortfall? Why should we be concerned about clubfoot treatment within our nation? We estimate that around 7,500 babies are born with clubfoots here in Pakistan. It could be more, but only half of those children are accessing clubfoot treatments using the Ponseti method. The rest are going untreated. The rest are developing preventable permanent disability, which means if we're seeing 3,500 children only, each year we are creating 3,500 permanent disability, which is avoidable. What can we learn from the Zimbabwe experience? Rehabilitation practitioners, that is us all sitting here, can be trained to effectively manage clubfoot. Teamwork and support is key for success. You may not be the direct clinician who's providing the treatment, but you can provide referral, you can provide information, you can provide support for those clinics that are seeing patients by making timely referrals and giving education to parents. Training, mentorship, and regular practice are key for quality treatment. You cannot work in isolation. You need to be working with all other Ponseti practitioners, making sure that you are consistently upskilling and making sure that you are using the best evidence-based practice. Early detection and referral is key. That allows us to see our children early and prevent disability from delayed treatment. Then good treatment results will build trust and satisfaction. Remember earlier on I said back home the parents were unhappy. They stopped believing in physiotherapists because they were using an inferior technique and getting poor results. So we need to make sure that we're producing good results. Then lastly, there is need to collaborate. There is need for holistic and collaborated care for difficult cases that need more than the conservative approach. Those cases that need surgery, that need referral to other specialists, pediatricians, neurologists, etc., so that we get the best care possible for all our children. So, as I conclude, what do I want to emphasize for us as the Pakistani rehabilitation and allied health professionals? Let us be inspired. Let us be inspired because real change comes with concerted effort that is thoughtful. So if we're inspired, we'll be effective. Let us be careful when we decide to major in areas of specialization. For instance, club for treatment. Some of these techniques are not as simple as they appear, and we need to work together so that we get the best results. Let's be collaborative and understand the importance of multidisciplinary teamwork and rehabilitation and surgical intervention. Let us be aware that rehabilitation interventions will not work without considering our patients and their parents' support and demand-side factors. Lastly, let us all be proactive. Let's seek knowledge, let's seek information, let us enable the community to refer to us by reaching out to them first. Thank you. There will not be questions, hopefully.
Thank you, Madam Deborah, for this informative session of Clubfoot. We are honored to introduce our next keynote speaker, Professor Dr. Qamar Mahmood. He is one of the esteemed authorities of the physical therapy. He has an impressive career of 32 years in physical therapy and specialization in pediatric and neurological rehabilitation. Currently serving as Head of Physiotherapy Department at National Institute of Rehabilitation Medicine. His educational journey, gold medalist status, numerous publications, and international certifications exemplify his commitment to the excellence. Today, we eagerly anticipate Dr. Qamar Mahmood's keynote speech on potential effects of traditional massage on spasticity and gross motor function in children with spastic cerebral palsy. Please welcome Dr. Qamar Mahmood.
अस्सलाम वालेकुम। मैं इंशाल्लाह कोशिश करूंगा कि इररेलेवेंट स्लाइड्स को मूव करूं और जो काम की चीज़ है रिजल्ट वगैरह उसको कुछ डिस्कस करें। तो टॉपिक चूंकि मेरा सेल पाल्सी से रिलेटेड है तो सिंपलेस्ट फॉर्म में इंजरी टू इमेच्योर ब्रेन कह सकते हैं। नीचे ये आपकी डेफिनेशन है जो कि अमेरिकन अकेडमी ऑफ सेल पाल्सी डेवलपमेंटल मेडिसिन ने लास्ट अपडेट किया 2007 में। इसकी वजह से टोन के डिसऑर्डर, मूवमेंट, पोस्चर के डिसऑर्डर लीडिंग टू एक्टिविटी लिमिटेशंस एंड कंप्रोमाइज क्वालिटी ऑफ लाइफ। तो टाइप्स में सबसे ज़्यादा स्पास्टिसिटी है, यही हमारी आज की यानी स्टडी का टॉपिक होगा, 70 से 80% है। द रेस्ट आर टाइप्स आर एथिटोसिस एंड एटेक्सिया एंड अदर थिंग्स। देयर आर सम फ्यू पिक्चर्स। तो प्रेवलेंस ग्लोबली 1.5 to more than 4 per 1000 live births रिपोर्ट्स हुई है। तो नो सेंट्रल डेटा इन पाकिस्तान, हाउएवर वी हैव ए स्टडी फ्रॉम स्वाबी in which 1.2 per 1000 has been reported. We have 6 million babies globally per year, and in Pakistan we have 12,000 cases. Growing up, a child with cerebral palsy needs 16 times higher financial resources than a child without cerebral palsy. There are many interventions. Of course, we cannot cure. We can provide better care to make the child independent as much as possible. So some medication, surgical injection, orthotics, physiotherapy, occupational therapy, speech therapy, psychology, and many more. So massage is included in one of the 64 interventions. There are now 2 types of massage globally are practiced. One are professional certified approaches, for which there is a curriculum, teaching, evaluation, and then certification. And few names are down. And this is also called complementary alternative medicine. And other types, in most countries, especially the underdeveloped countries, traditional approaches, no certification, no examination. The community person teach one another. So in traditional approaches, in Pakistan, parents use a traditional massage. This is called the traditional Pakistani massage. Differs with Swedish massage in application and technique and intensity. For example, Swedish massage we do basically distal to proximal, and in Pakistan we do from proximal to distal. And Pakistani massage is somewhat soft and superficial in nature. Literature, there is no literature about traditional Pakistani massage. However, there are many studies which say that massage can reduce spasticity. And the rationale of my study. So parents always ask that we should do massage or not. Because it is being practiced, we should work out that we should make a study whether it is useful or not. We have also WHO guidelines which says that research should be local resources based. If found useful, then it should be easily available, affordable, and accessible, especially in underdeveloped countries. So that's why this study was planned about traditional massage. There is a difference of opinion in Pakistan. I don't know the rest of the world, but there is a difference of opinion in Pakistan. Some professionals say that massage increases spasticity, while some say that massage don't increase spasticity. So it should be investigated. So this was physiotherapy department where this study was done. 84 sample size, and inclusion criteria: diplegic type cerebral palsy and age 4 to 12 years. Child should be able to understand the command. Exclusion: musculoskeletal disorders, ADHD, and other impairment visual type. There were random allocation into 2 groups. Both groups were provided conventional physical therapy comprising stretching exercise, strengthening, and positioning 5 times a week and for 12 weeks. However, at experimental group, traditional massage was additionally applied. This was 86 participants were enrolled to different groups, and then there were some dropout from 6 and 7. Finally, analyzed 75. We used 3 outcome variable. For spasticity, we use modified Ashworth scale, and for motor function, we used gross motor function measure and gross motor function classification system. These 3 tools are quite valid, reliable tools, and most commonly used. This modified Ashworth scale is graded 0 to 4. 0 normal tone, no problem, and 4 is severe rigidity. And gross motor function measure, we use check 88 items in different positions, and this is the scoring key. And one example, this type, this is the activity type. More score means better motor function. And gross motor function classification system, level 1 walks without limitation to level 5, yani transported in manual wheelchair, disabled and dependent on others. This is the something. Some assessment, there were 2 teams, one for assessment, one for training the parents about home exercise program and massage. It was parents who provided treatment at home, who were trained, well trained by the therapist, and they were motivated by weekly messages, tick marking the chart, bi-monthly phone call, like this. This is some data analysis procedure. Now the results. I think we should discuss from onward here. This is the relevant thing. This is the first chart, baseline characteristics. Here we have the variables, for example, gender, birthplace, nature of pregnancy. And on that side, red color, there is no p-values insignificant. This means that there was no difference at baseline between both groups. And this is the first our outcome variable, modified Ashworth scale of all 4 limbs. We took mean of all 4, both upper, both lower. And if you see down, extreme right, so this is the difference between, a significant difference between both groups. Similarly, if you see vertically down, within the group, control and experimental group, there is significant difference. So between group, there is a significant difference also at 6 and 12 weeks. So this is the graphical presentation of that. This is the second variable. We compare upper limbs and lower limb between both groups. When we see the upper limbs, there is a significant difference between both groups. And within group also significant difference at 6 weeks and simultaneously 12 weeks. And for lower limb, the significant difference took place at 12 weeks. At 6 weeks, it was not significant. However, within the groups, it is properly not working thing. At 6 weeks, significant difference, and about D2 discussions, results show, as we discussed the results, and one study was done by Bengal, functional massage along with traditional found significant reduction in the spasticity. And similarly, another study find the decline of spasticity. On the other hand, Rasool at Niram, he used deep friction massage and gastrocnemius, and Alizad used in Tehran Swedish massage, and McGregor used in the case series on the CP, they don't find reduction in spasticity. And this is the one variable comparing right side and left side. On right side, we find easily difference between both groups significant at 6 weeks and 12 weeks. And within group, of course, both groups significant difference. Graphical presentation. We see the left side. At left side, there is no significant difference. This is quite unusual finding. And we have repeated this analysis many times. So right side we find significant difference. On the left side, right upper and right lower, there was no significant difference. However, between group, within the group, significant difference in both groups. This is a graphical presentation. We also calculated each individual limb. We compare right upper, right lower, and left upper. The same result between group, right upper and right lower limb, significant change. Left upper and left lower limb, there was no significant change. And within group, all 4 limbs, significant change. If we see discussion, because right side there was a reduction in spasticity significant, and it has not been found in the literature so far, because no researcher, as per our information, has compared right side and left side. So what may be the cause? Yeah, possibility. One possibility may be the uneven distribution of tone. In CP, usually the tone at right and left side is sometimes it little bit uneven. So we thought that left side might be more spastic, that's why it responded less. But when we checked our results, grades, so it was right side more spastic at baseline. Even then it improved a lot. This means this is not the case, uneven distribution. So next thing may be effect of handiness. That some studies are showing that because we use one side more and we have better concept formation, then its motor activity is better. So this is a result from 2014 study that use of hand development, it results in development of perception, better quality, cortical output and improved motor function. Because right side is universally more common than left side. That's maybe the cause that in our case. So in our study there were two new findings. One is we just discussed right and left side, and another finding that in upper limb the significant change took place until 6 weeks. After 6 weeks, at 12 weeks it became insignificant in upper limb. In lower limb the significant change took place after 12 weeks only. It was gradual but 12 weeks. So it was also quite usual, and the literature is silent about this type of behavior. So possible explanation of this upper limb difference between lower limb may be the anatomical variation. We have some thin muscle here and some bulky muscle in the legs. Our nature of work, for example, lower limb use everyday closed chain activity, weight bearing, and upper limb use mostly the open chain activity in the space. This might be the cause. Our second variable was gross motor function classification system. It is one table, but if you see extreme right down, there was no significant difference between both groups. However, within the groups, experiment and control, there was significant difference. So between group, there was no signal. This is the graphical presentation. The last one was gross motor function measure. Again, extreme right below, you will see no significant difference between groups. So as per motor function, between group there was no significant difference. Within group you can find the significant difference. Graphical presentation. We also checked the subdomain of GM, FM. There are many subdomains, sitting, rolling, crawling. The result was same. All subdomain between group no significant difference, or within group there was significant difference in all domains, sitting, standing, jumping. The second objective of study of the gross motor function, if we compare the studies, so we have studies which has reported this finding. Rasool reported no improvement in the motor function. Similarly, in another study, McGregor reported the same. There is no change in the motor function between. However, on the other hand, in Taiwan, a study was done, 2 weeks per 12 weeks was investigated, and they found greater improvement in massage group with respect to total motor activity scale. In another study, 2018, functional massage was used. They also found the improvement, reduction of spasticity as we found, and improving some parameter of motor function, not all the parameter. We also made some correlations. This is the mass and GMFM significantly and negatively correlated. Mass and GMFCS significantly positively correlated. GMFM and GMFCS significantly negatively correlated. And its discussion. This is the result of our study. R value is minus 0.392 and P is 0.001. The comparison study has approximately same finding. R value is minus 0.339 and P value is 0.001, same value approximately. Another study significantly and negatively correlated. When we check the mass and GM-FCS correlation, 100% same result with one study. There is no change at all. This is the study of Malaysia, in which 48 children, our group size was 75. They also reported the same significant and positive correlation with the same value with our study. GM-FM and GM-FCS, this is the finding of our study. Significantly correlated. Approximately the same result here down. Conclusion. This study concluded that traditional massage can effectively reduce spasticity, does not have harm effects, so it can be administered safely by caregivers at home, making it suitable for the long-term management of spastic CB. Conventional physical therapy, which was used in both groups, is also effective in reducing spasticity. CPT alone and in conjunction with traditional massage is also effective in improving gross motor function. However, in case of gross motor function, no one is superior to other. Recommendation, there are few recommendations. Studies can be longitudinal, and last one is about this study. First publication was in Pakistan Journal of Medical Sciences, it is Impact Factor Journal, and second publication was Journal of Pakistan Medical Association, it is an Impact Factor Journal of Pakistan. And recently one manuscript has been accepted in Journal of Pediatric Rehabilitation Medicine, it is in Impact Factor Journal of Netherlands. Novelty and community application. So this is the first scientific evidence about use of traditional massage in the children with CB, the Pakistani massage. Two new findings were added to the current body of knowledge. We came across home-based exercise program found useful if carried out with effective distance supervision, training and guidance. This aspect might help in reducing financial burden encountered by parents. They have to move again and again, take the child, get some session. If they are trained to practice these sessions at home, so you can decrease their financial burden. At the same time, it can also decrease the workload on the public sector hospitals. This is a community application. And that's the thanks, some reference, and thank you very much.
Thank you, Professor Kamar, for sharing your experience with us. Now, our next speaker is Ms. Faiza Badr. Ms. Faiza Badr is a PhD scholar in rehabilitation sciences at ISRA University, Islamabad. Her expertise extends to her role as a manager of rehabilitation department and speech pathologist at Shifa International Hospital. Along with her position at Islamic International Medical College, Rifa University, Rawalpindi, and ISRA University, Islamabad. Ms. Faiza's profound contribution also include being a resource person at National Institute of Special Education. Please join me in giving a warm welcome to Ms. Faiza Badr to deliver a keynote on challenges encountered in introducing a dysphagia support group, Pakistan. Please welcome.
Bismillahirrahmanirrahim. Assalamu alaikum and good evening, everyone. My name is Faiza Badr and I'm a speech pathologist serving as manager rehabilitation department in Shifa International Hospital. I'm here from Islamabad, the second most beautiful capital of the world. So I will be talking about the initiative of introducing first dysphagia support group in Pakistan and the challenges we've encountered. Before I commence with my presentation, I would like to acknowledge the international audience we have with us today. The term dysphagia is pronounced differently in various parts of the world. However, in Pakistan, we often pronounce it as dysphagia, and during my presentation, I will be pronouncing it as dysphagia. I request your accommodation and understanding in this regard. So, why dysphagia support group? The question which keeps popping up was, can we create a dysphagia support group in a place where none existed? To make you relate with this topic and sensitivity of dysphagia, I would like to engage you all in a small activity. What if I ask you all just to stop swallowing for 2 minutes? आप लोगों ने 2 मिनट के लिए निगलना नहीं है, ठीक है? What I would like to share with you is that unconsciously we swallowed 2400